Hi, I'm Ron Berkman. We'll be covering some selected clinical challenges in contraceptive care. Hopefully, upon review of this and an accompanied video and the assigned readings, followed by a discussion session, participants should be able to discuss the risk of breast cancer with various contraceptive approaches, what contraceptive methods are appropriate for women with headache, the risk of venous thromboembolism with the use of various contraceptive approaches, what contraceptive methods are appropriate for obese women, what are the risks and benefits of various forms of emergency contraception, what are appropriate contraceptive choices for women with various pre-existing medical conditions. This particular video will discuss the material covered here in yellow, that is venous thromboembolism, obesity, and emergency contraception. So our first topic will focus on hormonal contraception and the risk of venous thromboembolism. And this is an important area because with the use particularly of hormonal contraception containing estrogen, clearly there is a risk of this particular problem. So the issues that I think are particularly important are which hormonal contraceptives increase the risk of venous thromboembolism. Are there differences by specific preparation? What groups of women are at particularly high risk for venous thromboembolism? And should women be screened for, in particular, factor V Leiden mutation prior to initiating hormonal contraception? Certainly there are a variety of risk factors. Clearly age, pregnancy, including the postpartum period. There are inherited thrombophilic and hemostatic disorders, contraceptive or replacement therapy hormones, particularly estrogen, certainly are risk factors. Obesity by itself, trauma, smoking, cancer, collagen vascular disorders. Clearly immobilization is a well-known risk factor. And recent surgery, particularly of a lower limb or deep pelvic region, are also risk factors. When we look at the number of venous thromboembolic events per 100,000 women years at different ages and look at non-users of birth control versus users, we can see that the attributable risk, that is the additional risk associated with pill use, is not all that high, though it does go up with age. So for a 20 to 24-year-old, that risk is about 6.5 cases or events per 100,000 women a year. And it roughly doubles by the time you become 40 to 44 at about 11.9 per 100,000 women per years. But again, overall, a rate that is not, shall we say, out of the ordinary from the standpoint of having to be very cautious about using these forms of birth control in low-risk individuals. When we look at the death rate, the same sort of picture is there. Overall, the death rate is low, ranging from about 1.3 in the 20 to 24-year-old to as high as 2.4, per 1 million women years here for the 40 to 44-year-old individual. Now, if you look at the development of the birth control pill, the first pills that were developed had estrogen doses of ethanoestradiol more than 50 micrograms. And you can see that there was an associated increased risk of venous thromboembolism per 10,000 women years that's certainly substantially higher than today's pills, which are less than 50 micrograms. Again, roughly a 2.5-fold decline in the risk as the dose of estrogen has dropped. Question often arises, what about the 20 microgram pill? Does that lead to even a further decline? And the answer is at best unclear, but is unlikely to show a substantially or exceedingly large decline. Further, since the events are so rare, it is a difficult area to study. So again, once you're in the 35, so we say microgram range, dropping to 20, probably, if any improvement, is probably modest. So, how have things varied in terms of the venous thromboembolic risk for estrogen-containing contraceptives? And much of the focus in the last decade or two has been on the progestin that is in combination with the estrogen. And multiple studies over several decades do suggest that the newer progestins in combination contraceptives do increase the VTE risk over contraceptives that contain, for example, levonorgestrel as their progestin. A Food and Drug Administration panel in 2011 did conclude that drospirenone-containing oral contraceptives and the contraceptive patch did have higher rates of venous thromboembolism, but clearly the benefits outweighed the risk. A Cochrane review in 2014 of 26 oral contraceptive studies suggested that progestins other than levonorgestrel carried a 60 to 80% increased risk of venous thromboembolism. But again, that risk is still in a reasonable rate compared to other issues such as pregnancy or the postpartum period. Of interest, a recent large German cohort study found no significant difference in risk among various progestins and oral contraceptives. And of some interest, the Food and Drug Administration recently revised the labeling of the ethanol estradiol norgestimate patch. That was the first patch that we had available for women greater than 30 in terms of their BMI due to an increased risk of thromboembolism. Again, suggesting it should not be used. It's contraindicated in those individuals. In terms of progestin-only contraception, there's limited data related to venous thromboembolism. So far, no statistically significant increased risk has been identified in the data that is available for users of intrauterine devices or the implant. However, a meta-analysis of 8 studies, again small studies with small sample sizes looking at the progestin-only injectable, Depo-Provera, did show a relative risk for users versus non-users of about 2.67. But bias and confounding was felt to be likely in many of these studies. So the bottom line is that there's no convincing evidence of a increased risk of venous thromboembolism with progestin-only contraceptives, except potentially for Depo-Provera use, probably in women maybe with multiple risk factors for cardiovascular disease, particularly venous thromboembolism. If we look at blood clots in women sort of in general, if you look at non-pregnant, non-users of hormonal contraception, you can see the rate is about 1 to 5 per 10,000 women years. If you drop all the way down to the bottom, you can see that women in the postpartum period have rates really of 40 to 65 per 10,000 women years. And then you look at particularly users of combined oral contraceptives with a rate of 3 to 9, and even the users of drospirenone with a rate of about 10. Again, these are rates that are all less than what would accrue in the postpartum period, and also less than what would accrue for a woman who's pregnant. So again, since we're using these to prevent pregnancy, you can see in the big scheme of things, the certainly risk of blood clot and so forth is certainly acceptable for users of these hormonal contraceptives. Keep in mind also there are a variety of things that affect thrombosis other than age, smoking, etc. And these are the availability of various clotting factors, some of which activate the thrombosis, some which inhibit coagulation and the like, and all do interplay. But of particular interest is factor V Leiden because of its prevalence in the U.S. population. Certainly it's the most commonly inherited thrombophilia, and its prevalence is about 5% in individuals of European descent in the United States. However, the annual rate of venous thromboembolism in carriers is about 0.4 to, let's say, 0.6 compared to a 0.2 incidence in the general population. So even with this increased risk of venous thromboembolism in carriers, what happens if in fact these individuals use hormonal contraceptives, particularly oral contraceptives? How does their use affect the risk of venous thromboembolism in women with this mutation? And sort of secondarily, should women be routinely screened for the mutation prior to oral contraceptive use? If we look at the study that really sort of focused all of our interest, and this is the one done again in Europe by Vandenbroek, which was a case control study looking at the DVT risk in OC users who did or did not carry factor V Leiden. So for the control group, the incidence was about 0.8 events per 10,000 women years. If a woman without factor V Leiden chose to use an oral contraceptive, it did increase their risk of thromboembolism to about 3 events per 10,000 women years. In women who had the factor V Leiden and were not pill users, there was a further increase in the risk of DVT to about 5.7. But when you combine factor V Leiden and oral contraceptive use, this risk went up to even more dramatically to an incidence, anyway, of 28.5 events per 10,000 women years. So how does this all work out in terms of what we should do clinically? So if we take this data and look at it a little more closely, as already shown in the last slide, the incidence of PE, that is pulmonary embolus, in women 15 to 49 with a mutation was about 5.7 events per 10,000 person years in non-pill users, but among pill users with a mutation, it rose to about 28.5 events per 10,000 person years. What about the incidence of death due to PE in women in this age group with a mutation? If they weren't using the pill, approximately 0.11 death per 10,000 person years. With pill use, that rose roughly fivefold to 0.57 deaths per 10,000 person years. Does this make a case for screening? Well, it really does not. In fact, if you sort of run the numbers and do your calculations, you would need to screen about 400,000 women prior to oral contraceptive use and identify 20,000 carriers who would avoid oral contraceptive use, potentially placing them at risk for unintended pregnancy, in order to prevent 1 death per year due to a pulmonary embolus. So certainly doing routine screening for factor V Leiden is not cost effective given the particularly overall rarity of mortality should one of these individuals develop a pulmonary embolus. So how do we conclude? Which hormonal contraceptives increase the risk of venous thromboembolism? Obviously those containing estrogen and perhaps Depo-Provera in high-risk women. Are there differences by specific preparations? There is some data that suggests users of the patch and drospirenone containing contraceptives may have higher risk, but in general the benefits outweigh the risks. What groups of women are particularly at high risk for venous thromboembolism with hormonal contraception use? This would include women with a prior venous thromboembolic event, older women, smokers, postpartum women in particular, women with inflammatory bowel disease, and women with thrombophilias or antiphospholipid antibodies. Should women be screened for factor V Leiden mutation prior to initiating hormonal contraception? No. Their only proviso would be if, in fact, there's some suggestion that there is a strong family history of venous thromboembolism and the family is of European descent, then perhaps screening might be in order. And when you look at the MEC diagram for this, you can see that certainly individuals with a history of DVT or active DVT and so forth are all candidates for not using combination hormonal products as shown here in the red and the pink. And certainly individuals with prolonged immobilization should not be on combination hormonal products, particularly if they've undergone major surgery. Next topic is obesity and contraception, and this is an area of certainly of some interest given that over 30% of the population in the United States is obese. And the question obviously is, does obesity affect the effectiveness of hormonal contraceptives? Are the risks using hormonal contraceptives higher for obese women? And does bariatric surgery affect the efficacy of oral contraceptives? In a Cochrane review of hormonal contraception in overweight obese women, they looked at 11 trials, including, again, overall about 38,500 women. In one study, using BMI, it did find a higher pregnancy rate with lower dose pills in overweight obese women. These would be, for example, the 20 microgram pills as opposed to the 35 microgram pills. With a patch, higher body weight but not BMI was shown in the studies to be associated with increased pregnancy risk. Vaginal ring studies did show higher pregnancy rates with weights greater than 70 kilograms. However, 2 implant studies show no trend by body weight. So again, potential, probably modest, perhaps some increases, but again, not sufficiently studied. It's important also to keep in mind that most randomized trials examining contraceptive efficacy until recently excluded obese women. So there really wasn't much data that you could see from these larger trials that led to approval of these agents. Further, there are a lot of observational studies, again with increased risk of bias, and these types of studies contribute most of the data in this area, and even that data is limited. The CDC in their MEC publications do suggest that benefits outweigh risks for use of oral contraceptives, the patch or the ring, with no restrictions to other forms. Important to recognize, however, that recent product labeling of a new estradiol levonorgestrel patch indicated that it is contraindicated when the BMI is equal to or greater than 30 due to increased risk of unintended pregnancy. What about venous thromboembolic risk? Again, one of the major risks that you would be concerned with particularly obese women. A Dutch case control study found that oral contraceptive users with a BMI greater than 25 compared to those who had BMIs at 25 or less had a 10-fold increased risk of venous thromboembolism. So certainly obesity or overweight did increase that risk. In a British case-control study, they found an increased risk with a BMI greater than 25, but once the BMI got to be equal or greater than 35, that risk was 3 times greater than that experienced by normal weight users. The Center for Disease Control in their MEC guidelines has no restriction to any form of contraception based on obesity, while the American College of Obstetricians and Gynecologists suggests more consideration should be given to progestin-only forms of contraception and IUDs. Of note, again, the FDA recently revised the labeling of its initial patch, indicating that it is contraindicated in women with a BMI greater or equal to 30 due to an increased risk of thromboembolism. Now, does bariatric surgery affect oral contraceptive efficacy? Like much of the data in this area, this issue has not been adequately studied, and there's limited studies overall. One study did demonstrate that 2 out of 9 oral contraceptive users in this small study became pregnant after a biliopancreatic diversion. Another study of 7 morbidly obese women after a jejunal ileal bypass did demonstrate that they had decreased levels of oral contraceptive steroids compared to controls. Again, both of these studies would suggest that there potentially is some decreased risk of efficacy. And this may be related to the type of bypass that one has. Certainly the malabsorptive procedures, such as the Roux-en-Y bypass, do decrease absorption of a variety of agents, whereas restrictive procedures such as the banding procedures do not. Although the data is limited, the CDC and their MEC guidelines do recommend against using oral hormonal contraceptives in the presence of malabsorptive procedures. However, there's no restrictions to the vaginal ring, patch, injectable, implant, or the levonorgestrel releasing IUD, primarily because the gut is not used for absorption of these agents. So, what does this tell us? Does obesity affect the effectiveness of hormonal contraceptives? Probably, but the data is limited. Are risks higher for obese women who use hormonal contraceptives? Clearly, there is some increased venous thromboembolism risk, and certainly one should, as ACOG has suggested, consider progestin-only methods, especially the LARC methods. Does bariatric surgery affect efficacy of oral contraceptives? Possibly, particularly with malabsorptive procedures, but the data is quite limited. Overall, for general use in terms of looking at individuals with a BMI greater than or equal to 30 or who had early menarche and have been obese for a prolonged period of time, again, there seems to be no substantive restriction to the use of any contraceptive agent, including combination hormonal products. Finally, let's look at emergency contraception, an area that certainly is important. And the topics I think are of usefulness are what options are available, are there differences among the options in terms of efficacy, and are there factors that influence the efficacy of the various emergency contraceptive options. And the options in the United States include Plan B, which is a levonorgestrel pill, and also has generic versions such as Next Choice, One Dose My Way, Take Action, and After Pill. We also have Ella, which is a ulipristal preparation, and the Paragard IUD. And you can see that all of these can be used up to 5 days after unprotected intercourse, but the sooner they're used, the more effective they are. If you look at the general efficacy and studies that were summarized by Cleland a while ago, you can see that the copper IUD clearly is the most effective of the 3 versions, followed by the Ella, which is the ulipristal preparation, and then the levonorgestrel preparation. In fact, a meta-analysis comparing 2 oral preparations to ulipristal did show 42 to 65% less risk of pregnancy when ulipristal was used instead of one of the levonorgestrel agents. But again, they are all effective, just that some are more effective than others. So what about when they are used? Does this change the effectiveness? And here is a comparison again of the ulipristal, that's Ella, versus Plan B, which is the levonorgestrel agent. And this data does also show that ulipristal is more effective than the levonorgestrel preparation when used within 24 hours of intercourse, or used within 120 hours of intercourse, that is somewhat later after the unprotected event. Again, suggesting that among the oral agents, ulipristal is more effective than is levonorgestrel agents. And this holds up too in other ways. If you look at the risk of pregnancy in obese women, and this is with women that have BMIs equal to or greater than 30, ulipristal basically is substantially more effective than levonorgestrel in reducing the risk of pregnancy. If you look at pregnancy risk with women who have further intercourse during the same cycle when they had unprotected intercourse, ulipristal also worked better than did levonorgestrel. Also, ulipristal compared to levonorgestrel preparation did have less nausea associated with it than the levonorgestrel agent. However, the downside of the ulipristal medication is that it is substantially more expensive, and in many locales it is not available over the counter as is levonorgestrel. So to conclude, what options are available for emergency contraception? Certainly Plan B, one step in all its various generic versions, Ella, and the copper IUD. Are there differences in efficacy? Yes, the copper IUD substantially better than the 2 oral agents. It's also important to keep in mind that if someone is not using any contraception and requires emergency contraception, the use of the copper IUD has a secondary benefit in that once it's placed and it is effective in reducing the risk of pregnancy for that cycle, it can continue to be used for up to 10 years as a method of contraception. Are there factors that influence efficacy? Yes, obesity and the timing with oral preparations or when further intercourse is carried out during that cycle.